Well, good afternoon and welcome to the NDARC seminar webcast. As you know, we're in these troubled times. We're attempting to keep the seminar series going, if anything, to get to a broader audience. My name is Professor Shane Dark and I'm convener of this series. Now, while we're dispersed four winds at the moment, we must acknowledge traditional owners of country throughout Australia, recognise their continuing connection to land, waters and culture, and we pay respects to their elders past, present and emerging. Now, our speaker today is Dr. Mithilesh Dronavali, who joined us just this year in January as a research fellow in biostatistics. He came from us from Liverpool Public Health Unit. His background is varied: medicine, biostatistics, psychiatry, epidemiology. Today he's going to be speaking on a very important topic broadly, which is causation in science, and it is an issue that is consistently vexed, and it'll be great to hear what Mithilesh has got to say about it, because attributing causation is core to all scientific endeavours, and that includes obviously the field of substance dependence. And in this presentation, Dr. Dronavali will examine the latest developments regarding causal inference. Now you can log your questions onto the God knows what that means, the Q&A Zoom function, which I will then relay to Mithilesh at the conclusion of the presentation. So without any further ado, Mithilesh, over to you.
Hi all, today I wanted to shed some insights on the topic of causation in science, in quantitative science. Please feel free to log any questions anytime during the talk. So what is science? There are many views of what science is, but I like to understand science as the discovery and measurement of reproducible effect. So if society knows certain effects which are reproducible, then society can plan in such a way that rockets can go to the moon, buildings don't collapse. And this reproducible nature of effect is what makes science so powerful. To measure reproducible effect in science, we need to reduce bias. Bias is the difference between the actual effect and the measured effect in your study. So bias has four components, and these include selection bias. So those participants in your study, do they represent the general population? And also, have you selected more of a certain type of participant compared to the other to give a lopsided effect value? Then there's measurement error. Does that mean are your instruments capable of measuring observations accurately? And then there's random chance. For example, what you measured in your study may be different to what is actually out there in the population, and this could be due to chance. To overcome random chance is usually to increase the sample size, the number of participants. Confounding bias is the last form of bias, and this is when the relationship between the predictor and the outcome is different from the actual effect because of other variables that affect both the predictor and the outcome. More details soon. So reducing confounding bias. There are two types of methods for reducing confounding bias in study design. One is RCTs, randomized controlled trials. If a randomized controlled trial is big enough, it can balance confounders between trial groups. And by balancing confounders, confounding is no longer an issue. But sometimes RCTs are not practical. So then there are observational studies. Observational studies can both describe the relationship between groups and outcome, or with that of an intervention that changes the group's progression to the outcome. So why are RCTs not always the go? Sometimes they're unethical. For example, philosophers debate that participants go into an RCT not knowing what the benefits are, but medical researchers always gain knowledge from RCTs. And then it further gets much worse when in places like Africa, where the RCTs are carried out, but the participants can no longer use the medication they were on in the RCT because of lack of funding. Then small RCTs don't actually balance for confounders sufficiently. And we cannot plan the sample size of an RCT to take into account balancing confounders, because we don't know what the confounders usually are and what the distribution of these are. And then RCTs have this long-term problem of patients crossing over, leaving the RCT or not complying. It's dealt with in two ways: intention to treat, like if you are randomized to treatment, you're considered to have taken treatment for the next 6 months or however, and that may not always be true or practical. And if you break the randomization sequence and just use the data as it happens, then that's not really a randomized controlled trial. So this is a small flaw in RCTs. And then of course there's the prohibitive cost. Running large multi-center trial RCTs with long follow-up is incredibly expensive because of the staff required and the clinical settings required. And then of course there's inflexibility. For a drug to be registered under a regulatory authority, usually you need to go through phase 1, phase 2, phase 3, and that could take 4 or 5 years. The problem is once a chemotherapy gets registered, by that time there's already 10 waiting to get registered who were discovered during that period. So therefore, regulatory bodies are investigating other study designs other than just RCTs to measure the effectiveness of treatments. Furthermore, you can't personalize treatments in RCTs because often the intervention is fixed and applied throughout all participants in the trial. And then there's the issue of them being too clean. So that means the cohort has, for example, no renal failure, no liver failure, no heart failure, diabetes under control between 20 and 60. And that's not what the general population is like. These strict criteria may measure an effect that is not reproducible in society. And then there is the challenge in certain fields where the therapist and the client have a certain fit, which makes RCTs, like difficult to measure because of this fit. This is also an example of Hawthorne bias. Observational studies. So you can't balance for confounders. So what do you do? Well, you do a thorough literature review and gain evidence from multiple sources, from tall mountains to small pebbles, so you can gain a broad and in-depth understanding of the issue. And then you draw a directed acyclic graph, which is basically a mechanism of causation from predictor to outcome with one-way pointing arrows. So why the DAG? The DAG allows for a clear conceptualization of the issue by the scientist so that he can or she can clearly communicate it to other scientists and the general public. By drawing a DAG, we understand what the variables are that are causing the confounding. And we can efficiently collect variables on the confounding variables that we actually need and not all the other ones. And this allows for more power in the analysis because we only adjust for those variables that we need. So confounding according to the DAG way, a confounder predicts both the predictor and the outcome. And you can see that by the arrows going from the covariate to X and the covariate to the outcome in one direction. The confounder is not on the treatment pathway between the predictor and the outcome. What happens when you haven't measured all the confounders that you'd like to? Because there are some that are unmeasurable and possibly too many. So then instrumental variables come to the rescue. And instrumental variables are very specific variables that cause the outcome only through the treatment. They do not affect any of the confounders, but they only cause the outcome through the treatment. And they're not on the causal pathway. So this is a classic study of instrumental variables. So a lot of debate has occurred on whether increasing serum high density lipids or HDLs decrease the risk of myocardial infarction. There's been so much debate like eating avocados and so on just to increase your HDL. I mean, not that avocados are bad, but the LIPG gene in certain individuals in the population increases serum HDL, which potentially decreases the risk of myocardial infarction. Note that this gene does not affect confounding factors such as smoking, alcohol, obesity, but only increases serum HDL. That's why this gene is gold in terms of instrumental variables. And this study has happened over like 10,000 patients in this setting where it sampled people with this gene and without this gene. And they showed that there was no association between high density lipids and the risk of MI, which is a significant study and very difficult to prove outside the instrumental variables setting. This was by Voigt et al. In 2012. No instruments. Well, then we have to, and also previously, if you don't have instrumental variables, another method of adjusting for confounding without measuring the confounders is difference in difference, which looks at trends over time between different groups. I suggest you look that up later in your own time. So then adjusting for confounders, the rookie error in this scene is the collider bias. So collider bias happens when the arrows go from predictor and outcome to the other variable rather than the other way around. For example, locomotor disease decreases mobility, and decreased mobility increases respiratory disease. So the hypothesis was that locomotor disease increases respiratory disease. So in the general population, if we use respiratory disease as an outcome and looked at locomotor disease as a predictor, then if we adjusted for hospitalization, there would be a link. But actually there is no link. And the reason is because locomotor disease and respiratory disease are both more likely to cause hospitalization and not the other way around. This is what a collider bias is. And you can spot these colliders after you have drawn a directed acyclic graph. Now I wanted to go through a more complicated setting. This is a much more tricky directed acyclic graph. So basically here we have a scenario where there is antidepressants, depression, and side effects of antidepressants. This includes insomnia and headache. In this diagram, all the variables are binary. That means 1-0. Either you have depression or you don't have depression. Either you take antidepressants or not, and so forth. Antidepressants lead to decreased depression. Antidepressants can cause headaches. Headaches worsen the depression. Antidepressants can cause insomnia. Insomnia worsens the depression. And also, the tricky thing here is that insomnia also worsens headache, and headache furthermore worsens depression. If we break down these parts into effects, the literature terms this process as interventional direct and indirect effects. So firstly, there is the path between antidepressants and depression. This is the treatment pathway. This is also known as the direct effect because it goes straight from the treatment to the outcome. This pathway is negative because antidepressant use leads to decrease in depression. A decrease in depression indicates a negative pathway. Pathway 2 is antidepressants increasing headache and headache increasing depression. This is a positive pathway as depression is increased, where headache is also increased. And the third path is antidepressants increasing insomnia, insomnia increasing depression, insomnia increasing headache, and headache increasing depression. This is also a positive path as all the variables are going up. And then the total effect of antidepressants on depression is the path 1, path 2, and path 3 combined. If we wanted to measure the effect of antidepressants on depression, just purely through their treatment effect and not through side effects, then we look at patients who have not had any side effects in the study. So basically that looks at the whole cohort and eliminates everyone who had insomnia and everyone who had headache. And then we look at the effect of antidepressants versus no antidepressants on depression versus no depression. The motivation behind all this mediator and confounding mediator thing is that had a person taken an antidepressant, did the depression go away? And what if the same person at the same time had not taken the antidepressant? Would their depression have gone away? And that's the fundamental cross-world assumption or alternative world assumption that these analyses are built on. These analyses don't allow for adjustment like in previous scenarios where you stick a variable in the end of a regression equation. And that's why these analyses are very tricky, because they claim a higher level of causation than other analyses. So back to this model, antidepressant treatment to depression in those who don't have side effects. That's path 1. Path 2, the indirect effects, which is via the insomnia and headache, are seen through a very simple way. Basically, we only look at the patients who took antidepressants. We remove all the other patients out because they would not have side effects because they took antidepressants. And they did not have side effects because they couldn't, because they never took antidepressants. And of those who took antidepressants, we have headache and insomnia and depression. So the way they do this without adjusting for variables is to look at, in that cohort that took antidepressants, the effect of headache on depression. So either you did have a headache or you didn't have a headache, or either you were depressed or you didn't have depression. So then how do they adjust for all the other variables like insomnia and any other variables they collected? Well, what they do is that they get an average effect from all the possible covariates in the data that are attributable to this directed acyclic graph. And how they do it is they look at the effect through the covariates using bootstrapping, which basically means they take out data and put it back in, and then they do it again for every single combination of covariates. And this gives an effect for the side effect pathways. Now I wanted to discuss, so the total effect is the indirect effect, which is the side effects pathway, and the direct effect, which is the antidepressant to depression pathway. So now the interesting bit comes when antidepressants and depression. How do we break down this effect into an effect decomposition? And why should we need to do this? Okay, so first of all, any odds ratio less than 1 means that the depression is going away. Odds ratios above 1 means that the depression is getting worse. So antidepressants to depression. This is the pure effect of the drug without any side effects. And the odds ratio is 0.22. This is basically the best we can hope for because this is the only treatment we're giving for their depression. And then antidepressants to headache to depression. So what is the effect of antidepressants to depression via headache? It's 1.12. What does that mean? it means that antidepressants are increasing depression through headaches by an odds ratio of 1.12. What about through insomnia? Remember, insomnia acts both on depression and headaches to depression. So insomnia, the odds ratio is 1.87. Note that the insomnia side effect is actually more powerful than the headache side effect in worsening depression. Looking at the total effects. So the total effects of the three pathways is what is normally seen in the general public. Basically, when you give an antidepressant to just about anyone, what is the chance that the depression will go away? And that's 0.47, and that's significant, right? The odds ratio is clinically meaningful, is less than 0.47. So I'd just like to note this data has been simulated on this artificial scenario, but the results are a real analysis of this data. So back to the decomposition, total effect of 0.47 is the effect of antidepressants to depression. But why did we could have got this just from an odds ratio 2x2 table. So why did we go through all this length to find out the different effects? Well, this is where the beauty of this analysis is. So if you take antidepressants and then you treat the insomnia, then your effectiveness of your joint treatment is 0.25, which means this is more effective than just giving antidepressants alone. But instead of insomnia, what if you wanted to treat the headache? If you treated the headache, then the effectiveness of antidepressants and the headache treatment combined would be 0.42. It's not much better than not treating the headache. And if you would treat both the headache and the insomnia, basically you've got rid of all the side effects of the drug, and the drug has a consistent effect with the outcome of 0.22 as mentioned in number 1. So why is this important? If you were a doctor or a health system and you had minimal resources, or you wanted to reduce the side effects of further treatment and further interactions with treatment, then you would want to treat insomnia and not the headache. I mean, in the ideal world, we'd treat both. But if we treat the insomnia, the effect of antidepressants and insomnia and treating insomnia is 0.25, which is just as good as the pure effect of antidepressants without side effects. So this is called interventional direct and indirect effects for a reason. It says, what is the intervention and where can we focus auxiliary interventions on the mechanism such that a maximal gain can be received and reducing harm the most. Now, this scenario can also be used in the substance abuse setting, for example, for drugs to control alcohol abuse, such as naltrexone, acamprosate, and disulfiram. Or it can be reversed potentially, where an intervention that causes harm can be ameliorated at various settings to make the outcome not as bad. So this is effect decomposition, interventional, indirect, and direct effects, and an overview of causation. So this is a very bold attempt at doing this because there's so much literature in causal inference that is not funny. There are other models such as the Bradford-Hill criteria, which look at a multi-pronged method of assessing causation. And this is one version from a confounding perspective. Okay. These are the references. Van Steeland and Elizabeth Stewart are big names in this field. And the second reference, John Carlin, he's a professor of epidemiology and biostatistics at University of Melbourne. So these are the, this is my talk. I look forward to any questions.
Thank you very much, Mithilesh. That's terrific. I suppose the first thing that comes to mind to me is I'm always pleased to see people that take some argument with the primacy of RCTs. And I'm thinking of certain funding bodies for which it seems to be almost some sort of a RCT affiliate. So, I mean,
The drug itself is the RCT.
yeah, well, I'm just wondering, how do you think one combats that there are alternate ways that are, and that there are indeed shortcomings with every methodology?
So this is a huge deal in epidemiology. It's the war of comparative effectiveness, which evaluates interventions in similar methods versus randomized control trials. And the annoying thing is that the regulatory bodies at the top, such as the FDA and the TGA, they only want to hear about RCTs. They haven't come on to the comparative effectiveness bandwagon as yet. But there are issues with this RCT thing, right? Like, for example, the COVID vaccination. I mean, maybe we can't have a 5-year protracted experimentation phase of the vaccine. What about chemotherapies? There's like sometimes 10 chemotherapies every 6 months, and you just can't go through the RCT method. So now we're looking at personalizing medicine, adjusting for the right confounders, and then genomic sequences. So there is a lot more happening in this space, and RCTs, while they're really good for some situations, sometimes they're just too clunky in that everything has to be perfect and the real world is not perfect and the trial itself is not perfect because people don't always follow what's there to be done. So.
Yeah. I mean, some years ago, the BMJ had one of their Christmas editions about randomized controlled trial for the efficacy of parachutes.
Exactly, I remember that.
But it had never been done before, so it could be confounded. So I recommend anyone to look up. It's making a very serious point under the guise.
Yeah.
I've got a question here from Anthony Shakesharp. Given a choice, is it preferable to focus on improving evaluation design or using stats methods to adjust for design flaws? Or is it,
yeah, I remember a cartoon back when I was in honors year saying, no amount of statistical methods make up for a good study design and well-performed study. So there's not much I can answer for that, but I think that all these methods can be incorporated into the study design so that these studies are more efficient in terms of cost and power perspective, and they get results much faster. So design and adjusting both go together, so yeah.
Okay. I mean, just to go back to something you said at the beginning with potential biases, one thing I do find, and you alluded to this, and I'm not sure what the solution is, but what you get, for instance, an outcome study on a opioid-dependent population, and you'll read to your astonishment that everybody with a comorbid psychiatric diagnosis was excluded. I think, well, that was everybody. So what you're left with is a group of people who actually
not only is the effect
very unusual. But I don't know, how does one approach that?
Not only is the effect wrong, but all those people who had mental illness, they need evidence as well, right? They need to show what interventions actually work for those with mental illness.
So it's an ethical issue as well.
Yeah, so it's not just finding the so-called effect. There are a number of ways which we can do this. We can restrict the data sets so that we could look at only mental illness patients or only without mental illness. We can also adjust in such ways like there are these things called propensity scores where you basically collect a lot of variable information about the patients and see, you know, were they more likely to get treatment or were they less likely to get treatment? And using this, they do adjusting as well. So there are many techniques out there, and the really bad way is to just exclude people because more data is better. I always think like that. Yeah, the wider the reach, the more likely your effects are reproducible.
Yeah, I think there's truth in that. I mean, there's always noise in the data. That's reality.
And the art of research and statistics is to remove the noise from the data as efficiently as they can.
Yeah, while still leaving it as meaningful.
Exactly, yeah.
Yeah. There was I've just got a comment from Janie Long who says, thanks for the great presentation and explaining it in a way that's easy to understand, which I think with. These are
I thought I was babbling a bit, but thanks.
No, not at all. And there was an asked question, obviously, wanting to know if your presentation would be available. I can confirm it will be on the website, NDART website, in the next week or so. So please have a look there. Now, here's a question from Thomas. Says, again, interesting talk, thank you. You should be pleased with statistical talks. This is high praise. Can these diagrams handle time-varying confounders?
Okay, so this is an epic question where the predictor causes the outcome, but then the outcome causes the predictor. So basically it goes in a loop going back and forth. An example that we discussed, how should I put it? Like, if you drink alcohol and you have alcohol abuse, you're more likely to lose your job. And if you lose your job, you're more likely to drink more alcohol. So what came first, the chicken or the egg, right?
Yeah.
So basically what they do is they look at the effect of alcohol on quality of life, and they adjust for unemployment in such a way that the directed acyclic graph goes from up to down. So like alcohol to unemployment to alcohol to unemployment. And the note that the arrow is going in the same direction, because time doesn't go backwards, time only goes forward. So the arrows go in the same direction. And then they use this technique called G computation, which you guys should look up. G computation removes the confounding that's interlinked and intermeshed that on going forward, and gives you a number on the effect of unemployment on alcohol and alcohol related harms in just one number.
Right.
And I wanted to say that the guy who invented this method was also a medical doctor. He didn't have much of a stats background. And then he published this in the 80s in some small remote journal. And then somebody picked it 20 years later, and then he became famous as a Harvard professor now.
There you go. Hope for everybody. We've got a question from the good Professor Weatherburn, no less. Don's asked, how does this procedure handle endogeneity, i.e. situations where the cause and effect influence each other?
Yeah, so that was basically the last topic that I just talked about, where it goes from one way to the other to the other. And for that method, there is the analysis called G computation.
Right.
Which breaks that linkage and finds the effect regardless of endogeneity. And I know Don is a big fan of instrumental variables as they break endogeneity as well.
Yeah, well, he's got a follow-up question. Also, isn't it only useful that this design, if you know all the confounders, and that the actual issue is really their interaction?
Yeah, okay. So this is a very important point with DAGs, right? What if you don't know the DAG? And what if you're just guessing the DAG? That's why the importance of the literature review is critical in drawing the DAG. And yet you still may get the DAG wrong. So that's why there's instrumental variables and difference in difference. But the efficiency of the DAG is that you only need to analyze the variables according to the DAG, and you only need to collect information on variables according to the DAG. Of course, you need a high confidence in the DAG, and when you don't have that confidence, you can't really do these intermediary effects. But you still need to draw some kind of DAG to convey to the reader and the other scientists what you're thinking about in your head. Because if you just write paragraphs and paragraphs, they won't get it either. The simplicity of the pictorial form allows for like communication with little additional writing. So that's why DAGs are important.
Less is more.
Yeah.
Yeah. I'm a minimalist by heart, so look, that's been an incredibly interesting presentation, and I think it's certainly expanded my understanding of this. And I thank you for taking us through a complex area, and I think reducing it to something that is readily comprehensible. Thank you very much, Middle. It's been a real pleasure to listen to you today.
Thank you for giving me the opportunity to do this talk, and I hope people can think beyond the scope of RCTs for their next study.
Just before I go, I should mention that next week we're having the week off. Our next presentation seminar will be on May 14, and we'll be delighted to have Professor Carla Trelaw from the Centre for Social Research in Health at UNSW speaking on stigma and people who inject drugs. And we're delighted to have Carla, but remember that'll be the week after next. It'll be up on the website advertised. Thank you one and all, and have an excellent evening. Goodbye.
All right then, bye-bye.